Okay, that was an awesome video from about Jim and his story. That was great, and I'm so glad to see that he's doing well. So now we're going to be doing breakout sessions where we're going to be stepping through various topics, and there's going to be some topics here, and then there's some topics over there. So in the brochure, you can just kind of see kind of what topics you want to see, and you can go to that room or this room and kind of hear about each one. And we'll chat probably about 20 minutes for each topic. And so this one right now, for the next 20 minutes or so, it's going to be on essentially eyes and MOGAD, optic neuritis, and we're just here to answer any questions you might have. We have some slides that we can show if we end up running out of questions, but you all heard from me this morning, but we also have Dr. Stephanie Syc-Mazurek. She is trained neurology residency at Mayo Clinic. She did her neuroimmunology fellowship. Now she's doing her ophthalmology fellowship, and she's going to be staying on as faculty at the Mayo Clinic. So Steph, you want to say hi?
Yeah, thank you. Thanks, Dr. Chen. So it's been really wonderful to see so many familiar faces today and to hear your stories, and just thanks for having me, and thanks for coming today and being so open and sharing. It's a great event.
So maybe we can just start off with some questions the audience might have. I know we had some questions this morning, but we kind of ran out of time and just had to move on. So if any additional questions that we didn't get a chance to cover about eyes and MOGAD.
Hello, I was wondering if you could talk a little bit about your pupil when you have optic neuritis. And because what happens is when you go to another provider, they may not observe it correctly. So could you speak of that?
Steph, you want to start?
Yeah, certainly. So the pupil is kind of the window to the world, right? And we look at pupils for many different reasons. So we look at pupils and how they react to light when we shine kind of a light in your eye. We also use the pupil as a way to look at the back of the eye and the optic nerve, and can look at that during kind of an attack of inflammation of the eye or optic neuritis, or kind of after an event of acute inflammation, and kind of look at the changes that we can see in the optic nerve. But particularly with the way that the pupil reacts, is the pupil reacts because of light and that light signal that goes down the optic nerve. And we have lots of centers within the brain that kind of control that pupillary reaction or that constriction that we see with light. What happens with optic neuritis is that there's damage to the optic nerve. And so that signal, that light signal, kind of is disrupted and might not kind of go back to those brain centers in the way that it would in a healthy kind of optic nerve. And so particularly when patients have kind of an episode of inflammation on one optic nerve but not the other, that light signal is different, kind of coming from one eye as opposed to the other eye. And we can see that clinically in several different ways. So one is that when we shine light into the eye, that affected kind of optic nerve might not react in the same, or that pupil might not react in the same way because the brain's not seeing the same light signal. So it might be reacting kind of sluggishly. So rather than constricting quickly, it's constricting more slowly. And then the other thing that we look for is something called an RAPD, or relative afferent pupillary defect, which means that because of the way that the light signal goes down each optic nerve, is that we can sometimes see a little bit of constriction and then dilation of a pupil. And that can be a really helpful tool, kind of as a neurologist or a neuro-ophthalmologist, because it can signal that there's been damage to that optic nerve. And it's kind of one of those objective measures that we can see that indicates that there's been kind of prior damage to the optic nerve. So you might find if you go to another provider kind of for local eye checks that pupil kind of might not react in the same way that someone who doesn't have optic neuritis.
Yeah, I think it's a very, very helpful tool that we do because it's purely objective. And so if you have an optic neuritis with decreased vision, we will notice that that pupil doesn't react that well to light, and then we'll know that's an optic neuritis. Obviously, we have other ways of confirming an optic neuritis like MRI, but up to 5% of optic neuritis won't show up on an MRI. But if there's decreased vision in that eye, we will see that pupil not react to light. So it's our way of confirming an attack. It is important, though, if you've had a history of optic neuritis and you didn't have complete recovery, you can have the pupil doesn't react to light perfectly. And so, again, it'll be important to kind of see what your new baseline is. So if you have a new attack, they can see, is it worse than it once was? So that's important, too. And so what you're going to see, the doctor, what they should be doing is flashing the flashlight between the two eyes about 2 seconds per eye. And if they're doing this for about 10 swings or so, then they're checking it correctly, and they're really looking for that relative afferent pupillary defect. They're looking for how well that pupil reacts to light compared to the other eye. And again, it's a very, very objective way of confirming an attack. I guess we can start.
Andrea Mitchell, MOG Project. I have a question if science has come to an advancement of repairing the optic nerve damage.
All right, I can chat about that one right now. So right now, unfortunately, we don't have a way of regenerating the optic nerve yet. In terms of where we are with technology, we can grow stem cells essentially in a dish. But the problem is we can grow an optic nerve essentially in a dish from stem cells, but the first connection from your eyeball, from your optic nerve, is actually in the middle of your brain. So it actually has to go very, very far before it makes its first connection, and we don't know how to make these optic nerve cells grow to where they're supposed to grow. And so the stem cells, I think, will be the future, but the technology is not quite there yet. We do have to caution you that there are stem cell clinics in other countries, or even in our country, that are kind of private, and they will charge you $35,000 out of pocket to inject these stem cells into your eye. And it sounds very tempting to do that because they can say, hey, look, I've got your optic nerve in a dish. Let me just put it into your eye. The drawback is, again, we don't know how to make those nerves grow to where they're supposed to. And so it's very costly, one. And then two, there's actually been patients who have gone completely blind from these injections because of inflammation. So not only doesn't probably help, there's actually risk and harm. So I would strongly discourage any stem cell clinics that are outside of, large clinical trials because, our science isn't quite there yet. A couple other things that you'll hear about would be in like Germany, there's this electromagnetic stimulation that they've been doing. The thought is to try and stimulate the signal that's there in the eye, in the optic nerve, and try and improve function that way. I can say that for sure it does not do harm. It will not do harm, but we haven't seen the best evidence that it helps. But if you happen to be in Germany and see this, it's called the Federal Institute. There's certainly no qualms about trying it because it won't do harm, but the stem cells can be dangerous. And then maybe one other thing that may be coming down the pipeline, they're in clinical trials now, is essentially if patients are completely blind in both eyes, so completely blind, they're doing cortical implants into the back of the brain. And so essentially putting a microchip in the back of the brain, and it allows patients to see a little bit of vision. So essentially we're talking about movement, maybe be able to count a finger. So the majority of patients, it's not going to be helpful for, because even though the vision is damaged after optic neuritis, usually the vision's still better than what we're getting with those cortical implants. But there are clinical trials with these if patients are completely blind, can't see light at all. Because the difference between seeing light versus no light actually is a big difference. We have circadian clocks in us, and so essentially when we see light, we know it's daytime. When it's dark, it's nighttime. So again, if patients are completely blind, that's something that we would encourage. But if you have any vision at all, these cortical implants aren't going to be helpful right now until the technology gets better.
Just to echo what Dr. Chen said, kind of my background was in a glaucoma lab, so looking at how we can see kind of cells that degenerate in the eye and the axon health in the eye. And actually, one of the projects that I did during that PhD was trying to use stem cells to kind of improve the health of the optic nerve. And just like in Dr. Chen was saying, it's really difficult to get those stem cells to go to the right place. And so, again, this was animal models, so very different, but oftentimes those cells would just kind of sit in that fluid in the back of the eye and cause massive inflammation, not only in the back of the eye, but in the front of the eye as well. And so just another, word of caution.
But I do think the future, we don't want to paint a bleak picture. Again, if we have it growing in a dish, there's just a matter of time before we get it working in animal models. And it, I do think it will be something that will help, patients in the future. It's just, we're not quite there yet.
So I had a question. The 2 times I've had optic neuritis, they do the eye exam through the front of the eye. And then they say, oh, your optic nerve isn't swollen, so there's nothing wrong with you. But, I had the severe eye pain and everything, and finally was able to, with the first time, convince them to do an optic MRI, and that's when it showed swelling in that optic nerve. But then when I had it again, they did the same thing, but they wouldn't do, the MRI, and were trying to act like, nothing was going on. For people like, and then I was told that there's some people like me where, the external exam doesn't show any swelling in that optic nerve, through this way. They have to do it through the MRI. Like, what do we do? How do we convince? Usually I'm going to the ER, and, I shared earlier, I'm from a small Alaskan community in Southeast Alaska. I mean, they don't ever want to believe me. How do they look at that nerve and they say, oh, there's nothing wrong. Like, what suggestions do you have for people like me who might have that, where it's not showing externally like that, but they do have optic neuritis when it shows up on the MRI? The opposite shows up on the MRI, but not the physical exam.
It's a great question. And so the optic nerve kind of runs from the back of the eye kind of to the chiasm before going back to the brain. And so you're right that in some cases of optic neuritis, when a physician is looking into the back of the eye, we don't see swelling of the optic disc. And it really depends on where the inflammation is occurring within the optic nerve. So if the inflammation of the optic nerve is near kind of the end of the eye that's closest to the eyeball, then we can sometimes see that swelling when we look in the back of your eye. But if the inflammation is further back in the optic nerve, we might not see that swelling. And so, as you said, that's where those other tests become so important. And so confirming that swelling or new inflammation, either through looking at an MRI, particularly with contrast, to be able to look at that enhancement is what we call when that contrast leaks, or doing other tests. So potentially doing an OCT scan or optical coherence tomography to measure the thickness of the nerve. That can sometimes pick up subtle swelling that we can't necessarily see at the back of the eye. But you're right, it becomes really, and then also the clinical exam, as we were talking about, kind of looking at the pupil and how things have changed over time. And I think kind of that comprehensive approach, or that multimodal approach of using a clinical exam, but also our imaging tools, looking at visual acuity, so how far on that chart can you read, and kind of putting that together to determine if it's a relapse is so important. And it's just really challenging, and I know that you've been through so much kind of without access to people that kind of have kind of that special expertise in MOGAD. And so I think sometimes even, I know Dr. Flanagan recommends sometimes people carrying that paper of the diagnostic criteria to explain what is MOGAD, and then maybe even a note from your local neurologist or getting them involved if there is an attack. Because as we know, patients with MOGAD, when they've had an episode of optic neuritis, they can have those fluctuating vision symptoms that might not necessarily mean that it's a recurrent episode of optic neuritis. And really trying to parse out those two is this another episode of new inflammation versus not, can take some time and additional testing.
Hi there. So I was just wondering, for individuals who have recurrent optic neuritis and also steroid dependency, is there any indication that after, long-term preventative medication, multi-year, that would affect the odds of having recurrent optic neuritis after stopping that preventative? Or is an indication of, steroid dependency indicative that you're probably going to have recurrent episodes with no preventative or similar kind of treatment?
That's a good question. And so the steroid dependency essentially means you're going to have to be on some kind of treatment to prevent the new relapses, because you can't be on steroids forever. And so that could be IVIG, SubQIG, tocilizumab. We've talked about some of the randomized clinical trials as well. And then the biggest question is, does this mean I'm going to be on medication the rest of my life? I think is the big question. And that's a very interesting question for MOGAD, because with NMO and MS, the answer is yes, you have to be on treatment the rest of your life. But with MOG, some patients can go into remission. And so sometimes what we'll do is, if a patient has a second relapse, maybe we'll treat them for 3 years to keep them kind of quiet. And let's say they're quiet for 3 years, then we'll maybe try coming off and see how they do. And then if they have a relapse, then maybe we'll treat them for 5 years, see how they do. And we just kind of push it, and then we'll know. Some patients just need to be on chronic immunotherapy, and some patients can come off. The reason why we sometimes try to come off at times with MOG is oftentimes if you know you've got the disease and you have a relapse, you can get access to very early steroids and often prevent significant, permanent, more damage from recurrent attacks. So, we can afford maybe one more relapse, every once in a while. But it's, again, a little bit different if you've got NMO or MS. It's just treatment forever.
All right, hi. I am gonna ask some questions from people who are joining us online, Dr. Chen. So I have, I think, 4 or 5 questions from people. The first one is, there's growing evidence suggesting that inflammation may affect distinct anatomic compartments of the optic nerve in different forms of optic neuritis. It remains to be determined whether the recently discovered biomarkers of optic neuritis, such as anti-MOG antibodies, play a pathogenic role or passively appear in response to an unidentified pathogenic insult. Have there been any further investigation on this? That's a great question, I just wanted to say.
That's an excellent question, and I wish with all my heart that I could answer it. I think it's an area of a lot of interest. If we could understand why one antibody affects one part of the optic nerve and why another affects another part of the optic nerve, or even why MOG affects the optic nerve at one time and the spine at another, I think those are all the questions that are really important to answer, and thank you for all of those who have participated in research to try to help us answer those. And then we are actively trying to understand how pathogens or infections or what triggers the immune system to cause a person to develop the antibodies in the first place. So again, I know that's a very vague answer, but it's an excellent question. There are areas of future research or current research, and hopefully maybe at a future event we might be able to answer them in a little bit more detail.
And in terms of the MOG antibodies themselves being pathogenic or a biomarker, again, still a lot of work to be done. With aquaporin 4 antibodies for NMO, we've worked that out. We know that's truly pathogenic. For MOG, it's pretty mixed out there. And so the exact mechanism and pathways we still have to figure out.
Okay. Next question is from Debbie. My optic neuritis did not show on my MRI, and after IV steroids for 9 days and IVIG for 5 days, the neuro-ophthalmologist said it doesn't see optic neuritis at this time and is questioning diagnosis. I am left with an area of inflammation adjacent to the optic nerve currently and still have blurry vision, eye pain, and vision disturbances. I was positive for MOG IgG, which I think is immuno whatever, but titer came back negative, and they are questioning MOGAD diagnosis. Have you seen other presentations of eye inflammation with MOGAD?
Yeah, so again, the question is this optic neuritis or not? And so again, we've got our MRI to be helpful to that, and that picks up 95% of optic neuritis, but it means it'll miss 5%. But if it were optic neuritis, what we should see is the pupil shouldn't react as well to light. And then after the optic neuritis attack, we should see damage to the layers of the nerve. We can actually see the nerve thin over time. And so if the pupils reacted perfectly during the attack of blurred vision, and a picture of the optic nerve, an OCT, doesn't show thinning of the nerve, let's say after a month, it probably wasn't an optic neuritis attack. But then there's other things that can cause blurred vision and eye pain. It could be something called iritis, which is an inflammation within the eye. There's a lot of other things. And in terms of the MOG being positive, but then the titer being negative, what that means is it's probably very borderline and probably considered negative. There'd be maybe rare cases where that may be a true positive, but for the most part, at least probably in our labs, that'd be considered a negative. But it could always be checked again, 6 months from now.
And making certain that that test was done in a lab with that live cell-based assay is really important, because that can help clarify whether it's a true positive or not.
Okay, the next question. How are we doing on time, by the way, Julie? We okay? One more question. Okay, so this is from Tamiko, and I think this is good just for everyone to hear. Any suggestions for finding appropriate eye doctors in other parts of the country that are better equipped to give prescriptions that optic neuritis that people with optic neuritis have into account?
Yeah, so I would say ideally it'd be a neuro-ophthalmologist. That'd be perfect. But again, there's not many neuro-ophthalmologists, and there's definitely a shortage of neuro-ophthalmologists in the US. So not everyone's going to have access to that. I think the second best thing would be essentially there's optometry and there's ophthalmology. Ophthalmologists are still going to know probably a little bit more medically and surgically about diseases than optometry. So again, I would probably find an ophthalmologist as opposed to an optometrist and like a lens crafter kind of thing. So then that's going to be your next step. But ophthalmologists, you should be able to find an ophthalmologist. And again, the knowledge about MOG and optic neuritis is growing very, very quickly. If you asked this question 10 years ago, only neuro-ophthalmologists knew MOG existed. But now you ask this question, really most of the general ophthalmologists are starting to know this condition and should be able to help make the diagnosis and help treat. And yeah, I think we ran out of time in terms of our session, but what we can do is at all the breaks, just come find us and we can answer any questions that anyone has.
Thanks so much.